The following podcast is part of a certified educational activity titled Building a Foundation for Enhanced Outcomes in Pediatric ALL, Guidance on the Asparaginase Component of Modern Therapy. Access the entire activity and complete the post-test at peerview.com/TAQ860. Downloadable slides and practice aids are also available.
Hey, good afternoon, everybody. Thanks so much for attending. For those of you who don't know me, I'm Rachel Rao. I'm a pediatric oncologist at Texas Children's Hospital, Baylor College of Medicine in Houston, Texas. And with me today is my colleague and friend, Luke Mace, who is an associate professor at University of Utah Huntsman Cancer Institute and Primary Children's Hospital. It's a great pleasure to talk about asparaginase today. All right, so we have a lot of objectives today. I'm not going to go through these in detail because I think they'll become apparent as we move along. So we'll go ahead and get started talking about one of my favorite topics, asparaginase, for the treatment of acute lymphoblastic leukemia and lymphoma for pediatric patients. Okay, so I'm going to start with a little bit of a historical perspective, mostly because I find it super fascinating. Really, the story of asparaginase started in the 1950s when a group of researchers, for reasons that are still pretty unclear to me, applied guinea pig serum to lymphoblastic lymphoma cell line and found that it led to pretty rapid cell death of those lymphomatous cells. It took the same research group about a decade to figure out that it was the fact that guinea pig serum had high concentrations of asparaginase that was resulting in the cell death that they were noting. And you can see in a graph from the original paper here on the left that the asparaginase activity strongly correlated with the anti-tumor effect. So why is asparaginase effective for lymphoblastic leukemia and lymphoma? Well, asparaginase, as its name implies, is an enzyme that breaks down the amino acid asparagine into aspartic acid and ammonia. And while our normal healthy cells have another protein called asparagine synthetase, so our cells are capable of making its own asparagine, lymphoblastic leukemia and lymphoma cells lack this enzyme. And so they're incapable of synthesizing their own asparagine and so require it from exogenous sources. So if you starve the environment of asparagine, then the leukemia cells shut down their protein production and thus die. So if you think about it, it's really the first precision medicine available in oncology, really leveraging the fact that there's a specific vulnerability in the leukemia cells that isn't a vulnerability in normal cells. All right, so fast forward a few years later, we have the report of the first in-human use of asparaginase. This is a case report published in the late 1960s of a child, an 8-year-old boy with multiply relapsed refractory leukemia. He was infused partially purified guinea pig serum. They actually took guinea pig serum, purified what they could, asparaginase, and infused it into this child. Not surprisingly, it was a pretty rough experience. If you read the report, the child was massively febrile to 104. He was tachycardic, hypotensive. He had rapid hemolysis requiring emergent blood transfusions, had like 10 hemorrhagic stools, prompting him to stop the infusion about 6 hours in. So while that was miserable, what the doctors observed in the days following was actually pretty remarkable. The child's white cell count precipitously plummeted, as did his blast percent. His infiltrated liver shrunk, as is his involved testicle. So massive improvement in his leukematous disease, really the first indication that this might be an efficacious therapy for the treatment of acute lymphoblastic leukemia in children. Now, fortunately, it was soon thereafter realized that not only is asparaginase present in guinea pig serum, but also synthesized by a number of bacteria. And so E. coli bacteria became the primary source that was then used to study the incorporation of asparaginase into multi-agent chemotherapy for children. And this is really a landmark study published in the New England Journal of Medicine 20 years later after that first report. So it took some time to get there, showing that the addition of asparaginase into standard chemotherapy dramatically improved outcomes compared to historical controls. That really ushered in the era of trying to optimize asparaginase therapy for acute lymphoblastic leukemia. And a host of studies, just a few of which are summarized on this slide, really showed the importance of asparaginase by basically demonstrating that more asparaginase is better. So if you look at studies comparing increased number of doses, increased duration of asparaginase, be it by giving multiple doses over a more prolonged period of time, or using an asparaginase that has a better pharmacokinetic profile. So native E. coli asparaginase has a longer half-life than native Erwinia asparaginase. All these studies really came to the same conclusion that more is better. Additionally, so if we look at sort of the evidence by addition, you can also look at evidence by subtraction. So this is a paper published a few years ago by my colleague Sumit Gupta looking at a number of COG studies that incorporate asparaginase therapy. And really this was prompted by the fact that, as we all in this room know, Arwenia asparaginase was subject to frequent and prolonged shortages. So Sumit wanted to ask the question, what happens to those patients who we cannot give Arwenia to, who need it after they've had a hypersensitivity reaction to their E. coli-based asparaginase? When I've asked Sumit why he asked this question, because the families were asking him, what does this do to my child's chance of cure? And he was really hoping that he would find it was not different. But to the contrary, actually found that if you missed one or more courses of asparaginase in our high-risk patients, the risk of relapse increased 50%. Additionally, very similar NOFO data published around the same time showed that patients who had to cut short their asparaginase therapy for toxicities, most commonly hypersensitivity, they also experienced an increased risk of relapse, as demonstrated by the data shown on this slide. So obviously, asparaginase is incredibly important for our patient outcomes. It's a really cornerstone of our ALL and lymphoblastic lymphoma therapy. So it's critical that we have consistent supplies. And fortunately, I think we're at a better place than we were a few years ago. But I would say that the landscape of asparaginase products is ever changing and has become a little bit confusing. So I'm going to walk you through the current products that we have available to us. And what I'll say is that the product availability and regulatory approval differs based on where you practice, be it in the United States or other countries, and varies a little bit based on your patient's age, as I'll walk through. So for the long time, for the last several years to decades, our primary upfront product has been pegylated E. coli asparaginase. So if you just take asparaginase out of E. coli in its native form, it's pretty short acting, and you have to give multiple doses over a certain period of time. But you can extend the half-life of an asparaginase product by adding moieties of polyethylene glycol, or PEG. And so what has been our primary product is a pegylated E. coli asparaginase called PEG-ASPARGase, and that's been available to us for some time. You can see some of the sort of relevant information about it. So it's long-lasting because of the pegylation. So by IV administration, it has a half-life of about 5 days, and by IM administration as well. Our FDA-approved dose right now is 2,500 international units per meter square, no more often than every 14 days for our younger patients, with a lower dose for our older patients, given the increased risk of toxicities, which we'll talk about momentarily. Now, as probably many of you in this room know, the products available to us in the United States have changed very recently with the transition from having PEG-ASPARGase as our primarily available product to a newer version of pegylated E. coli asparaginase called CowSpargase, or I'll just call it CowPeg. The same company, Servier, produces both of these products, and they transitioned from primarily providing PEG-ASPARGase to CowPeg back in December. So the products available to our patients have changed. Again, both of these are pegylated E. coli asparaginases. So the general idea is not changed. The only difference between these two is the linker between the PEG moiety and the asparaginase. I won't get into the biochemistry of it, but that minor difference actually leads to a pretty significantly longer half-life for CowPeg compared to PEG-ASPARGase. We said that the half-life of PEG-ASPARGase is about 5 days. If you look at that of CowPeg, it's 16 days, so it lasts much longer. And that's reflected in sort of the dosing recommendation. So the recommended dose is the same, 2,500 international units per meter square, but no more often than every 21 days. You give it less often compared to giving PEG-ASPARGase. It is not yet approved for our older patients, so it's only approved for patients 21 years of age and younger. So if you've got a 22-year-old or older, this product is not yet available to them. And I will say CowPeg is only approved in the United States, not yet available in other countries unless I'm missing some recent developments. The other difference is that CowPeg is only approved IV, not its IM administration. Okay, so I wanted to spend a little bit of time sort of thinking through the application of these two different pegylated E. coli asparaginase products. So what I say is that for individuals who use Dana-Farber-based protocols, you'll know that a large component of the consolidation phase of this therapy is continuous asparagine depletion. So essentially, you just give continuous doses of a pegylated E. coli asparaginase product over 30 to 36 weeks. So for PEG-ASNase, if you're doing 30 weeks of asparagine depletion, you're going to give a patient 15 doses. When you have CalPEG, it actually is an advantage because you can space that out and you're giving it only every 3 weeks. You can go from 15 doses to 10 doses. So that's probably an advantage for patients using this style of consolidation therapy for their patients. On the other hand, I think there's some sort of question about the utility and value of a longer acting product on a backbone like a COG backbone where we give intermittent doses of asparaginase throughout a patient's treatment. You'll see just sort of our two basic schemas, that of our standard risk patients and our higher risk patients. Our standard risk patients will just get that one dose during induction and another one during DI, and that's it. Even our high risk patients get pretty spaced out doses of pegylated E. coli asparaginase, one during induction, a couple during consolidation, DI, and IM2. So really pretty spaced out intermittent dosing. So you can't really subtract doses of asparaginase because you're giving this longer acting product. You do get a longer activity, but it's unclear, how that's going to benefit our patients because there's no outcome data yet comparing the two head to head. There is some toxicity data from 2 trials, one run by Dana-Farber and one run by COG several years ago, showing that the toxicity profiles are pretty comparable, but I think that's still a question for debate and one that we'll probably glean more information about as we're more commonly using CalPEG. Okay, so those are 2 E. coli-based products. But of course, as Dr. Mace will discuss momentarily, a subset of our patients will have allergic reactions to E. coli-based asparaginases. For those patients, it's really important that we have a replacement product available to them. And again, we talked about the fact that multiple bacteria produce asparaginase, and another bacteria that does so is Erwinia chrysanthemi. It makes its own version of an asparaginase. And that asparaginase, fortunately, has no immunologic cross-reactivity with the E. coli asparaginase. So you can safely substitute one for the other when a patient's had an allergic reaction. So for many years, the Erwinia product that we had available to us was native Erwinia chrysanthemi. Because it's only in its native form, as expected, it has a relatively short half-life of around 7 hours given IV and around 16 hours when given by IM administration. So because this half-life is significantly shorter than the days-long half-life of our pegylated products, you have to give multiple doses of it to achieve the same level of asparagine depletion that you do with every 1 dose of pegylated E. coli asparaginase. So the dose of Erwinase was 25,000 international units per meter square, given on a Monday, Wednesday, Friday schedule times 6 doses to achieve that same 2-week depletion of asparagine you would anticipate from a long-acting product. Unfortunately, as we know, that product was fraught with manufacturing difficulties that led to very severe and prolonged shortages of that drug, making it unavailable to our patients for some time. At this time, actually, there's no longer an FDA approval for Erwinase. That label was revoked, and so it's not even available at all in the United States. It is still available in many countries outside of the United States, however. But what we do have now, and Dr. Mace will go into great detail about this product, is a recombinant version of Erwinia asparaginase. So it's the same basic protein structure, for amino acid, it's the same. It's just synthesized in a more readily manufactured way. So this helps to overcome the limitations that we had that led to those prolonged shortages because it's much easier to make. From the trial that Luke will describe, we know that it's because it's basically the same protein, its half-life, we give by IM administration, which is currently the only FDA-approved route of administration, is about the same as Erwinia asparaginase that we've previously had. There are 2 FDA-approved doses currently, 25 milligrams per meter square every 48 hours, or 25 milligrams on Mondays and Wednesdays, with a higher dose, 50 milligrams per meter square on Fridays. And Dr. Mace will describe the rationale for those different doses. This is approved for pediatric and adult patients, so there aren't any age restrictions on the use of recombinant Erwinia asparaginase. Okay, so just to sort of summarize this part, we know that asparaginase is really a key component. And we know that because we've found studies that show more is better. We have studies that show less is worse. So it's a real cornerstone of ALL therapy. But I think as pediatric oncologists, if we had to describe our relationship with asparaginase, we would say it's complicated because we love the efficacy, but the toxicities are really unique and challenging. So we'll talk about a lot of those as we move through the slides today. So I'm going to start with just two cases, ones that we commonly encounter in our clinics. So let's say we've got an 8-year-old boy recently diagnosed with ALL. He's of normal body habitus, and he's preparing to start his standard BALL treatment regimen. On the other hand, we've got in the next clinic room our 22-year-old AYA patient. His BMI is 37. You're going to treat him with a pediatric-based high-intensity chemotherapy backbone. So I'll turn it over to Dr. Mason to say, when you think about these two patients, what are the factors that come to mind as you think about giving them asparaginase?
Right, Rach. I think these are good contrasting scenarios to look at that we all probably have had some sort of experience with. And I think, obviously age is important for us. I think, throughout our treatments, our therapies, our AYA adult colleagues know that, in general, they may not be able to tolerate our treatments as well. Not that they can't, but something to consider. And then some more recent work on BMI has certainly come to light with our colleague Eitan Orgel from CHLA has looked into this pretty extensively, and we know that there is a relationship with BMI and toxicity. I think it's important though to understand what you're talking about with BMI. Is it obesity? What's the BSA of the patient? How are we defining obesity in our populations? And I think those things are certainly important, and we should consider those as we think about what we're going to do for these two different patients.
Great. So certainly age and BMI certainly come to the forefront of thinking when you're comparing these two patients for sure. So let's first look at some of those unique asparaginase-associated toxicities and how they relate to age. So this is a really nice summary, sort of compiling the data, I think nicely highlighting the fact that some of the most severe and sort of challenging complications of asparaginase therapy that we deal with are associated with increased age. So if you just compare adolescents, adults in sort of this lighter blue and pediatric patients in the dark blue, you'll see that many of the really challenging ones like hyperglycemia, elevated liver enzymes, pancreatitis, thrombosis are all much more commonly encountered in our AYA population compared to younger kids. Additionally, as Luke mentioned, Eitan Orgel has recently done a very nice study looking at COG study patients, almost 5,000 of them, so it's a really nice cohort, looking specifically for risk factors of toxicity. And this was a good mixed population, so 25% of them fell into the AYA category, 18% were obese, and 39% had a BSA of greater than 1.5. And that BSA is significant because above that, your dose of pegylated E. coli asparaginase would fall above 1 vial. So 3750 international units is 1 vial of asparaginase. And if you're above 1.5 meters square, then you would get a higher dose than that. So that's just something to keep in mind. And what Eitan showed from this cohort was just as that prior slide I had showed. With increased age, you see increased rates of asparaginase-associated toxicities. And the older you are, the higher that risk goes. Additionally, when you look at BMI, just like with age, as your BMI increases, so do your risk for just overall toxicities associated with asparaginase. And you can see compared to even overweight patients, obese patients have a significantly greater risk of asparaginase-associated toxicities. Breaking that down even further, of course, we grade obesity from sort of least obese to greatest obese. And again, we see that with increasing sort of class of obesity, we have substantially increasing risk of asparaginase-associated toxicities. An odds ratio of 17.2 is quite striking. Additionally, so I often get the question, right, well, what about the tall, skinny kid whose BSA is high? Are they at the same risk as a patient whose BSA is high because they're obese? And so Eitan's data was able to sort that out as well. And what he found is if you have a high BSA with obesity, you're at significantly increased risk for some of those toxicities that we just talked about: hyperbilirubinemia, elevated ALT, and thrombosis, not pancreatitis of interest. If you look at the tall, skinny kid, so your BSA is high, but you are not obese, then your risk was not significantly increased for those toxicities. So really, it's just patients with both obesity and high BSA, they're at risk for those toxicities. It's not just having a high BSA, so it's not just about the dose you get. Okay, so are there ways we can overcome some of these risks associated with obesity? And that's something that we've all been thinking about. because we've all seen these patients and know that these toxicities can be dose limiting and at some points life-threatening. So there was a small study that came out a few years ago saying, okay, let's just look at patients who got more than 1 vial or less than 1 vial, so just based on flat dose alone. And what this study shows was that those patients who got less than a vial had lower rates of several toxicities associated with asparaginase compared to patients who got higher doses. So maybe not surprising. So thrombosis, pancreatitis, and not shown on the slide, hyperbilirubinemia were all associated with getting the higher dose. Of course, adult providers have been thinking about this as well because they often have older patients, many of whom are obese. And so they've looked at using lower doses, so less than 1,000 compared to higher doses for their patients, and overall have found lower rates of particularly liver toxicity when they use the lower dosing regimen for their patients. I apologize for those who use St. Jude or DFCI or other consortia. I'm a COG person, so I know that best. But I will say COG studies now allow for dose capping at that 1 vial for patients with obesity. So if your BMI is 30 or greater, or if it's greater than or equal to 95th percentile for your age, you're allowed to dose cap for those patients now in COG studies. We don't yet know if that is going to be associated with lower rates of toxicities. We don't yet know how that's going to correspond with outcomes, but we thought it was a reasonable measure to take given these high rates of toxicities seen in our patients. So there have been some other possible mitigation strategies explored, and I think a lot of these warrant some study and exploration. Right now, there have been no head-to-head comparisons, but a few of the ideas that have been tossed around is that maybe if you delay the dose, so induction is when we often see those kids with hyperbilirubinemia. After their day 4 dose, they show up on day 22 and they're yellow head to toe. So if you delay that dose until day 15 or later, there's some European data showing that you reduce the risk of that liver toxicity. Maybe it's just a less inflamed liver because you debulk some of their leukemia from it. Hard to say, but that's something that's being explored. L-carnitine is also being used as a potential prophylactic option, and that's going to be studied in the CCL COG study coming up soon. And then others, some people have hypothesized maybe it's the high peak asparaginase activity you get after a pegylated product that is associated with that risk. So maybe giving something like a short-acting product may be actually better. But none of those have been studied or compared. So it's a little bit too early to say that they'll be efficacious, but I think more to come. All right, so just a few quick take-homes on sort of this first part of the talk. Asparaginase is the cornerstone of therapy. We have to give it to our patients, and we really need to optimize its administration and limit the number of patients who have truncated asparaginase treatment courses. There have been a lot of changes to the asparaginase product landscape. It's been a little hard to keep up with, but I think ultimately sort of the dust has settled, at least for now, and I think we're pretty set on the products we have available. I think it's great that we're no longer faced with shortages of our winning asparaginase. That's been a real win for our patients. The toxicities are unique, incredibly challenging, and very specific, and I think it's really important to think about the risk for each specific patient you encounter in your clinic based on age, obesity, and other factors. All right, with that, I'm going to turn it over to Luke.
Thanks, Dr. Rao. Excellent, and thanks everyone for being here. It's hard for me to wait up here. I love to talk, and I'm sitting up here for 25 minutes listening. Now I get to be the star of the show. Okay, well, thanks again, everyone, and we'll talk a little bit. Rachel laid a nice foundation, I think, and we will kind of talk about a little more detail of some of the things that she went over, and also kind of interact with these kind of continued discussions about potential cases or scenarios that you might find ourselves in. And I think, this topic of hypersensitivity and infusion reactions, I see the questions that are already on the list here. There's several of them here. I think this is a hot topic for everyone. And, unfortunately, we don't have great answers here, but I do think it's important to think about some of these scenarios and how you would approach them. So we have this same 8-year-old, has a normal BMI, starts their PEG component. They come in for their consolidation day 43 therapy. Everyone in the room has experienced this, I assume. 10 minutes into the infusion, they have some itching, dizziness, no headaches, and some chest pain. And so, Rachel, what do you think about this? I mean, I'm sure you experienced this at high volume center like Texas, hypersensitivity or an infusion reaction. What do you think?
Yeah, that's why it's hard. Right? It's never clear just based on the description. It's almost never clear when you're in front of the patient. And this is a super common, I feel like, everyday experience we have. And it's really in the heat of the moment, I think, impossible to sort out. Some clues can be, are they just red to head to toe, or do they have hives? Any respiratory symptoms really make you think of an antibody-mediated reaction as opposed to an infusion reaction. But otherwise, the symptoms are intertwined. So, obviously, the first thing you have to do is do what's in the best interest of the patient, stop the infusion, monitor them carefully, have everybody, with all eyes on deck. And then you have to really, after things have settled, the patient stabilized, then you can start thinking through, was this an antibody-mediated hypersensitivity versus an infusion reaction? In this case, it's a later dose, so that makes it more likely. Other things about this presentation don't really help you a whole lot sort it out.
Right. Yeah, I think it's tough. This is the kind of exercise we go through with each other. Clinicians, nurse practitioners, pharmacists, nurses, everyone who's seeing these patients in this moment as we huddle around them to try and figure out what to do next. And so, we'll talk about this in a little bit more depth, hypersensitivity versus infusion reactions. I think if there was a crystal ball where we could predict this would be great, but unfortunately there's not. And as Rachel kind of went through, how these products are made, we are when we get exposed to something that's foreign to our body, that can be perceived as not good, and that's probably a good thing, right, in the end. But these things then produce antibodies, these hypersensitivity reactions. I love spanning the gamut of review articles, of which we've wrote a few, and I'm sure some of you guys have as well. Looking at the incidence of these reactions, 3 to 30% is what we've chosen here. I think it depends on how much of it you're giving the population, but we know there will be patients who have these true hypersensitivity reactions. But what about infusion reactions? This is we see this in lots of arenas when we're giving medicines like antibodies or chemotherapeutics, and it's due to this direct activation of the complement system at times, the cytokines, histamine release. I think the levels of ammonia, hyperammonemia, my favorite word to say, even though I'm not good at saying it, is something that happens, right? And we know that this happens. These symptoms are listed here. I think it's sometimes difficult to tell, right, between hypersensitivity and this, and it's always something to consider. We're not going to go into detail of this because in the interest of time, but something to be aware of. And these infusion reactions aren't antibody mediated, and so the possibility for rechallenging is there and probably should be done, but it's sorting this out, right, in our patients. And how do we do that? Rachel was talking, about some of these things. The signs and symptoms are always something to consider, but we'll see in the next slide how these things can overlap. I think there are some clues to help you kind of determine this, but it can be difficult. And then timing, Rachel mentioned this timing thing. And so I think, when you think about, getting exposure, that's what sensitizes your body. The second, time you see it, or the third time you see it, this is where your highest probability is to have a true antibody-mediated response. We do know that continuous exposure does decrease your incidence of hypersensitivity with PEG-related asparaginase. We've seen this in the Dana-Farber Consortium. We see this in the European studies that have used continuous exposure and not intermittent exposure. And then infusion reactions we know are most common with the first exposure, and they do decrease with subsequent exposures, but it doesn't necessarily rule it out, right? These are just kind of clues for the detective work that we try and do for our patients. And so what can provide clues? This is a table that I often reference in talks, and it's a great kind of review article. And when you think about these symptoms by body system and how to differentiate hypersensitivity versus infusion reactions, what isn't as helpful about this table is the overlap, right? But I've tried to highlight the things to think about. So infusion reactions, those things highlighted in red there, these are things that I think about, headaches, high blood pressure, rigors, right? We see that with some of our antibody-mediated treatments that we use. These are less likely, right, to be hypersensitivity kind of induced, but again, doesn't rule it out. In terms of the hypersensitivity, this is a lot longer list, I think, because, we want to make sure we're not missing this, right? And I think if you look at the respiratory section here, these are things that are hard to get past and ignore when someone's having respiratory compromise. But again, you taking the whole picture into account, I think I've highlighted in blue here the laryngeal edema or pharyngeal edema. I think this is really kind of a telltale sign, right, of hypersensitivity, and some great work from Seth Carroll and Hirota Inaba have really shown this to be true. But again, not everyone who has a hypersensitivity reaction has this kind of manifestation. One of the things, and we'll talk about the clinical trial that with recombinant Erwinia, but one of the things that Rachel and I spent a lot of time on when we were discussing this trial and working through the data is our best friend, the CTCAE. And if you look at the CTCAE version 5, I think it's important to highlight that they talk about allergic reaction and infusion-related reaction, and they have different grades for each of them. And we think of them often, like even when you're seeing a patient in clinic and you're trying to think about how to describe what happened, these things can overlap. And I think knowing that these things exist and thinking about them is important. I think in general, it can be difficult, like we say, but at the bottom there, true hypersensitivity, you usually see increasing severity with more severe manifestations. I think the grade 2 versus grade 3 is where we get a lot of questions about this, and we certainly did in the trial. And again, looking at these, referencing these when you're seeing your patient, trying to figure out what to do next is important. When we talk about hypersensitivity and infusion reactions, you can't not mention pre-medication. Another one of these topics that we could spend a whole hour on discussing. I think in general, right, we have come to the belief that pre-medication is helpful, right? We use it for antibody therapies, we use it for blood products, IVIG, and we're always giving that as well. I mean, we're using pre-medication a lot of times, so why not try it with something like asparaginase, where you have these reactions that can be difficult to distinguish. What type of pre-medications you're using? There's a question here already that I read about, is antihistamines, is that useful? Steroids, that's what the kind of the hallmark is of pre-medication. This work by Stacy Cooper and Pat Brown at Hopkins really kind of established that, pre-medication may be helpful for patients. You see in the orange how many patients had to have substituted Erwinia for reactions, and how many had significant reactions pre them instituting pre-medication. In the blue, you have after they started pre-medicating, you have this kind of decrease. Of note, again, this is a single institution study, and I think when we're evaluating evidence for things, it's important to point out some of the weaknesses. And I think there's plenty of reports out there that say pre-medication does not help, but it is a tool in the toolbox and something that is mentioned in every asparaginase FDA label, as we know, and we'll talk a little bit about that going forward. So, thinking about how we treat patients with hypersensitivity versus infusion reactions, these are the options that we can consider, right? If you have an infusion reaction, really re-challenging a patient is our duty. As Rachel said, if you're missing these doses, it's not good. And if you want to make sure that you're treating your patient kind of correctly, as close to the protocols that we can. If you're having a true hypersensitivity, right, we have these two options here. There was this time when, as Rachel described, we didn't have an Erwinia-based product. We had to resort to other tools in our toolbox, and desensitization is something that people have tried and people have reported on and used. Again, not as frequently utilized now that we have an Erwinia product that's available for patients, but something of note. And then, discontinuing therapy is the last thing that we want to do. But sometimes, you're not going to tolerate asparaginase, and then, you have to kind of deal with those situations. So now we'll talk a little bit more about the recombinant Erwinia product, and I judge a medicine importance by how hard it is to say the name. So I think this one is very important, right? So recombinant chrysanthus-based Pseudomonas fluorescens, say that 10 times fast. So this product, also known as JZP458, is a non-E. coli derived asparaginase. It's very similar amino acid sequence-wise to the Erwinia based product. And then we know is recently approved for the use of multi-agent chemotherapy in patients who have developed hypersensitivity to an E. coli-based product. So I've talked about this a good amount, and I'm sure some of you have heard some of these discussions before. But again, just to review, this was a phase 2-3 trial that was conducted with the COG in collaboration with Jazz Pharmaceuticals, and it included patients who had a grade 3 or greater allergic reaction to an E. coli-derived product. We had two parts of the study, included an IM cohort, an IV cohort, each of these cohorts got 6 doses of drug on Monday, Wednesday, Friday schedule. And then the duration kind of depended on how many doses they would need in their schedule. I think it's important to point out we collected a ton of PK data on these patients. These were the time points that we assessed asparaginase activity levels, among other things. And it did produce a trove of information on a good amount of patients. As Rachel said, we're still kind of learning about some of these newer products because they're newer and not as many patients have gotten them. So we set this bar of a serum asparaginase activity level of greater than or equal to 0.1. This is an internationally agreed upon threshold. Again, another hour could be spent on this, but suffice it to say, that's what we set our goals at. We had 3 different cohorts in the study with different doses. As you see here, indicated at the bottom, the dark blue is the last 48-hour serum asparaginase activity trough, and then the light blue is the last 72 hours. Focusing on our cohort 1C, because this is kind of the dosing that was most recently kind of approved by the FDA. We met our goal of 90% of patients achieving this greater than or equal to 0.1 level. If you look on the right, again, just for kind of completeness sake, you can see these are the mean asparaginase activity levels, and our mean levels are really above 0.1. Again, this is a compilation of the raw data that was produced by the trial. Looking at the adverse events that were witnessed in the trial, breaking these down by treatment-related, serious 3-4. But I do think this column, again, is the most important ones. Who are the people that had to discontinue on drug based on side effects? And you can see at the lower dose, less patients, but at the 25-50, about 10% of patients had to discontinue drug. And as Rachel kind of reviewed the side effect profile of asparaginase products, this is within the realm of what we would expect with these medications. We spent a specific amount of time looking at special interest AEs, and these include some of the stuff that Rachel did talk about. And we'll talk a little bit about these two as well. If you see, we did have some patients have hypersensitivity, but not an extreme high number. We did see some patients with pancreatitis, and the thrombosis burden for the patients was rather low in this cohort of patients. And so when we think about, monitoring these patients who are getting asparaginase therapies, now switching gears a little bit, we have the AYA patient. We give this, he or she gets this multi-agent chemotherapy regimen with their asparaginase, Rachel, and on day 15 of their consolidation, they get their dose. The 7-day asparaginase activity level is less than 0.013. What do you think about this scenario, and what will we do next?
This is one of the situations in which serum asparaginase activity level or therapeutic drug monitoring is proven very helpful for our patients. And this is a patient with silent inactivation. So not only do the antibodies against asparaginase cause allergic symptoms in patients oftentimes, sometimes even without symptoms, those antibodies also degrade the drug. They're neutralizing antibodies, meaning that they eliminate the drug from your body, and so it's completely ineffective. So not only are those antibodies potentially causing a life-threatening reaction, but they're also degrading the drug, rendering it completely ineffective. So this is a patient where they would need to switch products to something that's non-E. coli based.
Absolutely. And there's questions already in our kind of question list about silent inactivation. And I think it's a fascinating topic and something that we're learning more and more about as more people are utilizing asparaginase activity levels. And if you're thinking about switching, what type of regimen would you choose? I think, again, it depends on what your resources are, what the patient preferences are, and we'll talk a little bit about kind of the options that a patient may have. But again, I'm a COG person as well, and we're just more familiar with these guidelines, and this is what's in our protocols in terms of assessing and grade or diagnosing silent inactivation, checking these levels at these certain time points, and then if you're not reaching these troughs, then this is something that you need to look out for. People have looked at the rates of silent activation. That's a question here. I think it's TBD in my opinion, because we're not really sure yet, because there's not a ton of data on this, but it's about 5 to 10% in those studies that are out there and reported. And we know that you need to really consider switching to an alternative formulation, because there's really nothing that we know of at this point that can kind of get past this silent activation situation. And so So we know there's two regimens for recombinant Erwinia. So if we have to use a different derived product, this is the product that is available in the U.S. We have these two different regimens that hopefully gives people some options. They're listed here, the 25, 25, 50 on Monday, Wednesday, Friday. And then below that kind of dosing, you'll see it talks about 67 hours, 48 hours, 53 to 58 hours, right? And there's a question about that in this, and we'll address that. Or you can use the 25 milligrams per meter squared, and again with some specifics about timing. And while these specifics about timing I think are important, I think it's also important for people to really be kind of more realistic about what happens in hospitals. As we know, they're not as well-oiled machines as we would like, and so scheduling this infusion on Monday, Wednesday, Friday, really based on each patient's circumstances is what we do. I don't tell my schedulers that you have to schedule this Friday patient, and get Erwinia at 7 p.m. because that's not really safe or feasible. So again, I think these timelines are important to know, but again, these are based off of recommendations, and I think in the real world we know how things go, right? And then you have this pre-medication recommendation, and it is in I think all asparaginase product labels now, and it talks about being recommended. I think the practice certainly varies with a pegylated product and non-pegylated product. I'll tell you, I think, and Rachel and I have had many discussions about this, giving a 3-year-old IV Benadryl 6 times in a row, 3 times a week or whatever, 7 times. I mean, I don't think that's something that's in their best interest. And so, I don't typically pre-medicate patients for this product. And on the study, it wasn't required, and it was just left up to people's discretion. We didn't really have a huge problem with hypersensitivity in with this product either. So again, I think, considering the patient, the situation, and what you're dealing with is something to consider when you talk about these subjects. And now, again, this is another topic that often comes up for us, and we get emails, weekly about this. I think when you think about how many doses, right, that you need to replace a long-acting product with, I think this is something that has, again, become a little bit of a hot topic because of where we're at with the long-acting products, as Rachel kind of alluded to. And so there's this table in the label for recombinant Erwinia that discusses this, and I think it's important to point it out, but also again think about what we do in the real world and what kind of we recommend as a treatment kind of body. And so you have these two doses, 25 milligrams per meter squared every 48 hours, or the 25, 25, 50. This column on the far right talks about if you're replacing a PEG-ASNase product, how many doses of recombinant Erwinia you should use to complete that course. And this is pretty standard in what we would expect. But then you think about the CalPEG product, and as Rachel mentioned, it has this SC linker in it that makes it the half-life longer, and we know it lasts a little bit longer in the system. So because of that, there was a recommendation that came out to replace the 25 milligrams per meter squared with 11 doses of recombinant Erwinia, or 9 doses, depending which kind of regimen you're using, if the patient was scheduled to get CalPEG. What I think is important, and what Rachel and I kind of have emphasized when we get questions about this, or when we're talking about this and teaching people, is what is your, as highlighted here in green, what is your intended duration, right? In our COG protocols, our intended duration of depletion, as Rachel mentioned, is based on PEG. It's based on PEG-Asparagase, and that product, is about a 14-day kind of duration. And so based on that, we are, the COG is recommending, and we've put this out before, that, these are the replacement number of doses you should be using, kind of regardless, for our patients. Rachel, any comments about that?
I agree. I think if you're using a Dana-Farber protocol and you're going to give 10 doses of long-acting to get your 30 weeks, then you should use this recommendation. And COG, what I tell people is our intended duration has not changed, only the products available to our patients. We know from decades worth of COG data that the intermittent dosing we use that is expected to deplete asparagine for 14 days results in the outcomes that we are all very familiar with. and the toxicity profile we are all very familiar with. So in my opinion, our intended duration is still 14 days. And so we should give the Erwinia asparaginase to achieve that same intended duration. And so that's what on COG studies is recommended based on a memo that was posted for all of our protocols.
So we'll move over these next few slides pretty quickly. Rachel kind of already talked a little bit about some of these toxicities, and we want to get through this to, in the best interest, so we can get to the questions, which I think there's so many good ones on here. There's no way we can get through them all, but we're going to get through as many as we can. So what if our patient developed asparaginase-associated toxicity, thrombosis? We think about withholding treatment and anticoagulation. We'll talk about this. Pancreatitis, which Rachel mentioned. These interventions do vary by grade. And then, we talk about the really severe events and how we would deal with that. And then liver dysfunction, which Rachel had talked about already. So when we think about asparaginase-induced venous thromboembolism, again, there are very few studies that kind of describe this in great detail. We know that, if you have a side effect like this, it's important to withhold asparaginase until the acute symptoms resolve. We talk about how to treat. We use low molecular weight heparin most frequently in pediatrics. There's a question on here about DOACs. I think it's a great question. I think, again, it's a newer type of intervention, and we're still learning more. I'll talk about this on the next slide. How long do you treat? This is also, can be debated, but I think, you treat for as long as you need to treat, and then you think about kind of prophylaxis if you're continuing the therapy at further dates. And then for significant thrombosis, obviously you're going to look for inherited predispositions. When we talk about prophylaxis, I think this is a hot topic in Sarah O'Brien's study that was conducted, in collaboration with COG and pharma, talked about, used apixaban versus standard of care to prevent thromboembolism in induction. And she found that there was some significant reduction in this. And I think there'll be more to come about prophylaxis. And we can talk a little bit about our practices as well, based on one of the questions we have. And then when looking at pancreatitis, I think this is, in my mind, people talk about hypersensitivity as being the worst. I think pancreatitis is the worst kind of side effect that you can have from PEG, because it's difficult to deal with. You have long-lasting effects, and you talk about how to supplement that. The Europeans that looked at this, in detail, and this is a review from the Ponte group that talks about these types of how to classify pancreatitis, abdominal pain, elevation of enzymes, and then imaging findings. I think what's most important to us, right, is, can you re-challenge those patients? And the Europeans have put out some good data that is successful at times, about half the time, kind of depending on severity. They looked at, certain factors to try to see which would be associated with a lack of success with re-challenging. We really haven't found that yet. This was another European-based study. The Norwegians, or the NOFO group, I should say, looked at this, and they had about a 7 to 10% rate of pancreatitis. They looked at their second exposure rates. Again, very similar kind of second incidence of pancreatitis, around 40 to 50% of patients. I think it's important to say that in the patients that were challenged, re-challenged, there hasn't been a very large amount of really kind of grade 5 events. And so, but it is a challenging thing. I think you think about age, as Rachel talked about. This is from that same kind of NOFO evaluation in the blue. The younger patients seem to have a little bit less incidence of pancreatitis. But again, we know it occurs in all age groups. And so when we think about how we modify, this is again recommendations from kind of the COG, and I think mild grade 3 is where it kind of is a little bit, there's this gray area, right? And you kind of have to assess the situation. Significant grade 3, certain associated symptoms and findings, really should think about discontinuing the drug. So looking at kind of our take-home messages, so we want to differentiate between hypersensitivity and infusion reactions. This is challenging. We need to be aware of silent activation. Recombinant Erwinia is safe and effective, as we reviewed some of the evidence from that. And then you do have these kind of these associated asparaginase side effects that do require kind of special consideration. So now we have some time here to go over some questions. I think we can kind of go through here, the list here, Rach, and then see if there's anyone in the audience that's brave enough to get up and to use a microphone. But would routine asparaginase levels in PK be part of our future? I think this is a great question. I think in general, like there's 2 labs that do this. It's it's accessible, and I think monitoring levels is something that we do frequently. I think if you're pre-medicating patients, right, you have to monitor levels. That's an international kind of recommendation. But I do think it's becoming more and more commonplace in the United States anyway.
Yeah, and in Europe, most of their studies have centralized asparaginase activity monitoring. So I think it is already standardized there. It's less so in the U.S. We've left it to the discretion of the providers, at least on the COG side. But that may be something that's changing, especially with the ever-changing asparaginase product landscape. Okay, so I'll take next question. I think we've covered a lot of these questions sort of as we've gone along. Let's see. Riley said he did not require premedications. Do you think environmental exposures to asparaginase, in parentheses, dietary effect hypersensitivity? That's a great question, really interesting one. I'm not sure about asparaginase, but some of the allergic reactions to our pegylated products has been shown to be to the PEG moiety itself. The very first COG trial I ran actually was pegylated Erwinia asparaginase. How awesome would that be, right? The problem was our patients, 3 of the 4 that we actually enrolled, God, that's so sad to say, 4 patients on a trial that I spent 2 years of my life on, had allergic reactions. And what it ended up is that they reacted to the PEG moiety, right? That's the commonality between, PEG asparagase that they got and the pegylated E. coli. And there is a lot of polyethylene glycol in the products we use, foods, makeups, exposures in vaccines and other things. So there's some suggestion that maybe increased environmental exposure to PEG moiety might predispose to this, but I think that's really kind of a murky area. And we haven't seen increased rates of asparaginase reactions with changes in diet or products. So I'm not sure that's going to sort of pan out, but it's a really interesting question.
Yeah, I agree. And here's one about T-cell ALL, which is near and dear to my heart. I mean, does T-cell ALL missed doses of asparaginase affect outcomes also? This is a great question, something we've talked about within the T-cell kind of groups within COG. We're looking at this. I would expect that the answer to this is yes, but to my knowledge, not great data on that subject to this point. But we're trying to collect that.
The question regarding patients that have PEG-induced pancreatitis and then have their asparaginase omitted for the rest of therapy, increased rates of relapse, lower survival rates. So the NOFO data included any patient who had omitted asparaginase therapy and showed increased rates of relapse in those patients. And similarly, Sumit's data didn't limit it to patients who just couldn't get Erwinia because it wasn't available. It was anybody who didn't complete all their courses. So yes, those data support that in patients who have truncated asparaginase therapy for whatever reason, they have increased rates of toxicity. Now, what I will say is there's one, I think, kind of important caveat, is that Sumit's data really showed that in our high-risk patients, so patients being treated with that more intense chemo backbone, missed asparaginase led to increased rates of relapse. However, on our standard risk patients, they only get that 1 dose in induction and the 1 dose in DI. Those patients actually didn't have worse outcomes if they missed some asparaginase. So I think that's kind of an important consideration. And so when I think of actually asparaginase in the context of someone who's had pancreatitis, one of the most important factors that I take into consideration is what is this patient's risk of relapse? If it's sort of that mild grade 3 and it's a kid on a standard risk backbone, I might just omit it because there's a 50-50 chance that they're going to have another occurrence of pancreatitis. If it's a 14-year-old with T-cell ALL, I'm more concerned about their risk of relapse if I drop this really important component of therapy. So I might be more likely to re-challenge those kids. I base my re-challenge on not only the toxicity that they had, but their risk of relapse.
Yeah, I mean, again, like the individual situation is so important. Be nice to have a nice algorithm for this, but really it's hard when you have many different kind of scenarios. How quickly should you be prepared to switch formulations after confirming hypersensitivity or silent activation? I think there's some data out there that says you should really not be right. We want to try and stay on our schedule, on our our protocol schedule, right? This is where our outcomes come from. I think within 48 hours is ideal. 72 hours certainly. When you start getting past that, then you're starting to delay other treatments. And as Rachel will tell you, being a study chair right now, I mean, then you're delaying the time point when you get your MRD results You're not on the schedule, and I think that isn't ideal. But again, the most important thing is replacing the doses, and so however long it takes, but really trying to get your team ready and responsive to these things. I think if you are having issues with getting the replacement product, this is something that you can communicate to your suppliers. You can communicate to Jazz itself, and they're really committed to getting you guys the product as soon as you can, because they know how important it is. So keep that in mind.
These lights are blinding. So if anyone has a question out there, please let me know. Otherwise, we'll keep going with the online ones. When using Monday, Wednesday, Friday Rylaze dosing, how early on Friday can the dose be administered? Whenever you want to give it, frankly. So I just like to kind of put into context why the recommendation is in the FDA label. Okay, so in addition to the observed data from the trial, pharmacokinetic modeling was used, and that's really a basis of a lot of drug approvals nowadays. So it's not outside the norm. But essentially what the FDA did is they took the PK curve, right? And they put a confidence interval around it. And wherever that confidence interval, the bottom of it, fell below 90% of patients being anticipated to be at 0.1, that's where they cut it off. Okay, so you'll notice I think it says like 68 hours from the Friday dose to the Monday dose. That's because if you look at the confidence interval around that, at the 68-hour mark, the bottom of the confidence interval was 90.1. If you went to 69 hours, it fell to like 89 point something. Okay, so I think if you sort of weigh the risk of having potentially a patient fall below 0.1 on a Monday, to me, that risk is way less than trying to give somebody an asparaginase product at 8 p.m. on a Friday. So frankly, just give it when you can. Don't change your clinic workflow. Don't make the patient go to, all kinds of different, family situations to try to get there at a specific time on Friday. We didn't require that in the trial. We just said give it on Friday and Monday. Give it when it makes sense for the patient and your clinic workflow.
Yeah. It's important to kind of understand that context too, I think, as you explain that to your teams in general. So any situations where you might use the every other day Erwinia, or is Monday, Wednesday, Friday preferred? I think this is a common question we get. I mean, I think it's nice to have options, but then sometimes people get confused. I don't think that there is one scenario where, say, I would definitely use that one or use the other one. Again, it's more kind of what your institutional resources are, what's the family's kind of preference. If you have to use every 4 to 8 hours and that patient's going to have to either come into the clinic on the weekend or be admitted, as a short stay or something like that. So I think that there's really not an advantage either way. From my perspective. So again, I think either is acceptable and whatever kind of works best for the patient in your kind of particular scenario.
Rachel.
Yeah. Sorry, we're a little bit over time. But
Hi, Rachel. Luke,
Hi.
Thank you. Branco here. Hi, quick question. Are there any studies on capping doses and outcomes?
Right. So not to my knowledge. And again, that was one caveat that I mentioned. We've allowed this in COG protocols based on the data that it's potentially going to help with some toxicities, right? Because I guess if you're preventing a dose-limiting toxicity, that's probably preferred, but we don't yet know about the outcome impact. It's a great question. I would say that adults have been using lower doses for some time, and their outcomes overall are pretty good as long as they're able to safely give asparaginase. But it's still a question to be answered, I would say.
Yeah, I agree, Branco. I mean, I think that we need to be we need more data on activity, levels at certain time points. And if you don't need to have this high of a dose in certain scenarios, I don't think we should be using it. So yeah.
And we're collecting the data we're asking patients on COG CRFs, have you capped the dose, yes or no? So I think we'll get those data eventually, but not yet. Question
maybe
here. I just got a notification that my flight's delayed, so I can stay. How long y'all want?
Hi there. I'm Jamie. I'm a fellow at Children's Hospital Los Angeles. I have a quick question, maybe a little naive, but is there a discussion being had about dose adjustments for Erwinia based on age and BMI as well?
Great question. Something that we get a lot. We're not having those discussions. It's not something we've done. We didn't do it on the trial. We didn't see any correlation between BMI and toxicities on the trial. Again, there's of course a caveat. This is not a naive question, by the way. Great question. That they are these are small numbers, and so we need to gather more data, and we're certainly in talks about doing that. just that is trying to look at some of these things. But we have done some small individual type looks at the data, and it doesn't seem to be that there's any kind of signal. But again, it's a smaller cohort, but something that we would think about.
That's a great question. I'm going to take one more question here. Assuming a patient experiences severe pancreatitis with PEG-ASPARGase, can alternative forms of asparaginase be used safely? I'm going to highlight this because no. If you've had a severe pancreatitis to asparaginase, that's any asparaginase. You cannot replace that with a different version of asparaginase. If you have to stop asparaginase therapy because of pancreatitis, that is inclusive of any asparaginase product. Any questions at all there? All right. I think with that, we'll wrap it up, and thank you guys for your participation and attendance.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/TAQ860. This program is supported by an independent medical education grant from Jazz Pharmaceuticals.